Chers collègues, geachte collega, j'ai le grand plaisir de vous accueillir ce soir pour le webinaire organisé par la Société belge de dermatologie. Het is mijn groot genoegen u te mogen verwelkomen vanavond op het webinar georganiseerd door de KBVDW. It's my great pleasure to welcome you this evening to the webinar organized by the Belgian Dermatological Society. This evening we have some prestigious national and international speakers. Professor Lidia Rudnicka from the University of Warsaw, who is present in the studio. Dr. Leopold Secco from University of Catholique de Louvain, who is also present in the studio on my right. Professor Ulricke Blume-Peytavi from the Charité, University of Berlin, who is online. And Dr. Axel de Greef from University Catholique de Louvain, who is present also in the studio on my right. This evening, webinar focus on alopecia areata. This disease can have a dreadful impact on the patient's quality of life, so we are eagerly awaiting new therapies. This evening program will consist on the following topics. What are the trichological signs of alopecia areata? And this will be overviewed by Professor Lidia Rudnicka from Warsaw. What is the histology of alopecia areata? And this will be introduced by Leopold Secco. What do we know about the pathophysiology? What are the new insights in the therapeutical landscape? Pathophysiology and new therapies will be presented by Professor Ulricke Blume-Peytavi from La Charité, Berlin. And finally, Dr. Axel de Greef will tell us about his experience with baricitinib, an anti-JAK inhibitor. This webinar is funded by sponsors. We thank them for their support that has permitted us to invite prestigious speakers and organize this webinar. It's my pleasure now to leave the floor to Lidia Rudnicka, and I leave you the possibility to send questions on the chat that are asked to Lidia at the end of her presentation. Thank you, Lidia, for being here.
Thank you very much. Thank you, Véronique, for the nice introduction. Hello, everyone. It's my pleasure to be here in the studio in Brussels. And, you know, we have, all of us have seen multiple patients with alopecia areata, so we may think, why should we have a presentation about the diagnosis? And I hope that today I will convince you that this is a major issue, especially in the context of new therapies. Alopecia areata can have many faces, but also alopecia areata may be mimicked by different diseases. When you take a look at the screen and you would like to think which of these patients on the screen have alopecia areata, sometimes it may be difficult to make the diagnosis. And I'm not sure whether I would surprise you, but none of the patients with focal alopecia in this image has alopecia areata. In the context of new treatments, and especially in the context of immunosuppressive treatments, most of these diseases would be a contraindication. So for this reason, the diagnosis is really crucial before we start therapy. Sometimes in even easy locations such as this, we all know ophiasis, the ophiatic form of alopecia areata. However, now we know that frontal fibrosing alopecia can look very similar, and also traction alopecia can be misdiagnosed as alopecia areata. So there is now a new consensus, European expert consensus on alopecia areata. It will be published, I hope it will be published soon. And our point of view is that the diagnosis of alopecia can be established on the basis of clinical examination, but also trichoscopy, and in doubtful cases, we would also perform a biopsy for histology examination, and there are even more diagnostic possibilities, which I will be talking about a little bit later. Today I will focus on trichoscopy. A trichoscopy can be performed with any health dermoscope, just as we have it for skin cancer, but also those of us who are more into dermoscopy or more into trichoscopy will get a big video dermoscope which gives the possibility to take images with higher magnification and to store the images. In a trichoscopy, the most typical sign, which we do not even need a dermoscope for, are the exclamation mark hairs. The exclamation mark hairs, when they are big enough, when they're bigger than 4 or 5 millimeters in size, we can see them by naked eye. If they're 1 millimeter in size or less, we need a dermoscope. And when we take a look at the exclamation mark hairs, when a hair is growing, it is having the shape of an exclamation mark hair with a thick distal end and a thin end at the base, because as it grows, it becomes thinner and thinner and thinner. So today I will show you different possibilities of visualizing this in trichoscopy. But before I do this, just to mention that the exclamation mark hairs are the typical feature of a very active disease, of a very active alopecia areata. They are quite specific for alopecia areata. However, there may be some diseases such as trichotillomania or toxic chemotherapy-induced alopecia where there may be some exclamation mark hairs as well. So we can say, and this is a little bit more for the experts, so we can say that exclamation mark hairs are more a type of feature of anagen effluvium, and alopecia areata is an anagen effluvium. And when we look in a patient for the exclamation mark hairs, we will always look at the hair-bearing margin. Now we have several exclamation mark hairs, like these 3 in the image, and we may think, what can happen with an exclamation mark hair? Let's take a look at the first one. We will see that the exclamation mark hair, as it grows, it becomes thinner, 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 thinner. Finally, it will break off. What happens if it breaks off? A residue of the hair shaft will be remaining in the hair follicle, but from the perspective of a dermoscope, it will just look like a black dot. And these are the black dots, which are another typical feature of alopecia areata in trichoscopy and also a feature of active disease. But what else can happen with an exclamation mark hair? It can keep growing, growing, growing. It becomes thinner, 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 but never thin enough to break. And these hairs we call the tapered hairs. These are very, very long exclamation mark hairs. And I will talk about details just in a moment. And a third option is the hair keeps growing, it becomes thinner, 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 and then the patient comes to see you in your office. The patient receives the right treatment, and then the hair starts becoming thicker and thicker and thicker again. So what will happen? The hair will grow and it will have a constriction along the hair shaft. And we call this the Paul Pincus constriction. And let's go into the details. These are the black dots. The black dots, as mentioned, these are the visible parts of a hair residue which was broken at the level of the scalp. Usually in a patient with alopecia areata, we will see multiple these black dots in the active phase of the disease. The tapered hairs are defined as hairs, as an exclamation mark hair in which the distal end is outside of the field of view. So there is no like a very specific length. It just depends on the type of dermoscope you will be using. And also the Paul Pincus constrictions, very important to not misdiagnose, especially in a child with monolatrix, because monolatrix may look very similar. Monolatrix, as we know, is a genetic disease with a deformity of the hair shaft with multiple constrictions along the hair shafts, and this may look very similar. As a clue for the differential diagnosis may be that in monolatrix, usually the constrictions will be equally distributed along the hair shaft, whereas in alopecia areata, they will depend on the activity of the disease, so they will be in irregular distribution. And some rare signs of alopecia areata and trichoscopy, less than 2% of patients. This is trichorexis nodosa. Trichorexis nodosa may have many different causes, and it is a situation in which the hair splits into multiple fibers. It becomes weaker in this area, so it starts to bend, and when it bends at very sharp angles, it will form the so-called zigzag hair. The zigzag hair have been described in 2 diseases, in very active alopecia areata and in tinea capidis, rare, but sometimes when visible, it may be a hint for the diagnosis. So now let's look at the exclamation mark hair. What else can happen? Of course, what we would like to happen mostly is that that the hair breaks off, but then a new, normal, healthy hair is growing. And this is the most appreciated picture of upright regrowing hairs. Sometimes it makes the patient a little bit happy that we as doctors, the patient does not see the regrowing hair in the mirror yet, but we see them with a dermoscope. So this is a good sign for both the doctor and the patient. Sometimes when the hair is regrowing, but the environment of the hair is still abnormal, there's some inflammatory process going on, it may regrow not in a straight form, not as an upright regrowing hair, but it may form a kind of circle, and it has been called either the circle or the pigtail hair. And this is an image which shows both of them. In the lower left part of the image, you see some regrowing hairs, and in the right part of the image, some hairs which regrow, forming a type of pigtail picture, and this is why we call them the pigtail hairs. And here again, our exclamation mark hair, when it breaks off, sometimes it happens that it breaks off and nothing happens. Nothing happens for a long time, and then what we will see in this area will be just a yellow dot. And why do we see the yellow dot? The yellow dot develops because if we have a hair residue in the hair follicle, the body will usually not leave the hair residue for a long time. It will be degraded, and the hair follicle remains empty. But it will not remain empty because the sebaceous glands are still working. The sebaceous glands will pump sebum into the hair follicle opening, and a mixture of sebum, which is yellow, obviously, and with keratotic material will form the picture. Looking from the perspective of the dermoscope, it will look a little bit yellow. And the typical picture of a long-lasting alopecia areata you see on the right side of the image, multiple very regularly distributed yellow dots. This is a picture of alopecia areata, which I would guess lasts for at least a year or 2 or 3. So we see no regrowing hairs, just some yellow dots. So the yellow dots are a sign of long-lasting alopecia areata, but also I would like to go with you together through the question whether or not it is possible to have long-lasting alopecia areata with no yellow dots, because these are the most difficult cases to diagnose. And yes, it is possible that you have no hair, no regrowing hair, no black dots, no signs of alopecia areata, and no yellow dots as well. This may happen in children, in elderly patients, in a very, very long-lasting disease. And let me explain why. As mentioned, the yellow dots develop when the sebaceous glands are active. And the sebaceous glands are most active in patients who are teenagers and young adults. So sometimes in children and sometimes in elderly people, we may not see the yellow dots. And if it's a long-lasting alopecia areata, and the hair, this is the second situation, and the time goes by, the hair follicle is empty for a long time. What will happen, as with any organ, that that is doing nothing, it will become atrophic. So it will become smaller and smaller and smaller until at one point it will be destroyed and it is replaced by fibrotic tissue. So in a very, very, very long-lasting alopecia areata, and the question how long it takes, nobody knows, there may be a follicular dropout. There was recently a discussion because, of course, when you have a situation of a follicular dropout, you will have no chance for regrowth anymore. So it is believed that it may happen after 20, 25, 30, or maybe or more years of no hair regrowth in the patients. However, this is a very simplified picture. You will see that in real life, it's not a black and white situation. So in such a situation, we will see an image in trichoscopy which will resemble cicatricial alopecia. So just to summarize trichoscopy, an exclamation mark hair, black dots, tapered hairs, and the pulpingous constructions. They are the features of most typical active phase of the disease, and then the hair may regrow, either as an upright regrowth, the regrowing hairs, sometimes as a circle hairs or pigtail hairs, yellow dots, as mentioned, long-lasting, and sometimes we will see vellus hairs. There's a discussion going on about the clinical value of the vellus hairs in alopecia areata. However, for those of us who just don't want to remember all these details, the three most important trichoscopy features of alopecia areata are the exclamation mark hairs, the black dots, and the yellow dots. And with the knowledge of these three features, I think we can very well manage maybe 90% of our patients with alopecia areata, maybe even more. And because I am sitting next to Véronique, I wanted to say a few words about other imaging techniques. And I was a big fan of reflectance focal microscopy. We were even the first one to publish a hair paper on RCM. However, there is a problem with RCM for alopecia areata that when you look at the inflammatory infiltrates, and we will have a talk today about the pathology of alopecia areata, they are very deep, and RCM is only covering the upper part of the dermis. So this method was not perfect for alopecia areata, but now we have LC-OCT, which gives an image which may be either vertical or horizontal. And this is from a recent paper by my coworker, who has shown the difference between alopecia areata and trichotillomania in LC-OCT, showing on the left side a pulpingous constriction and on the right side a damaged hair in a patient with trichotillomania. To be honest, I believe this is really a method of the future, and probably not now, because now it's extremely expensive, but I believe that in 10 or 20 years, almost everyone in our will have a machine in his or her office or as being a dermatologist. With this, I would like to kindly thank for the invitation. Thank you for having me here. Thank you for listening. And for those of you who are very interested in hair, I have a YouTube channel, so please feel free to take a look. Thank you.
Thank you, Lidia.
Thank you very much.
I don't see a question, but maybe Dr. Axel.
Dr. Rudnicka, it was really graphic and very educational, and you made it seem easy. I really appreciated the kinetic you presented of what hair becomes during alopecia areata and how the trichoscopy follows. And I was just wondering, you talked about the exclamation point in trichotillomania, and I'm surprised because it's usually this sign that I use to be sure it's alopecia areata and not trichotillomania. And I was wondering how do you explain the exclamation point in trichotillomania.
Yeah, they differ a little bit when you look, but there's not much work on this. And most of the work has been done in the microscope, not in trichoscopy. When you take a look at the exclamation mark here of alopecia areata, we were talking about the proximal end, which is thin. But also, please take a look, the distal end is also thin. So it's thin, thicker, thin. So it was broken off, it grew thicker, and then it breaks off again. And this is the pathology of alopecia areata. Now, in trichotillomania, when you pull and it breaks off, usually it breaks off a little bit like uneven, but not thin. So it breaks off, and then the new hair regrows. And the new hair regrows, it will be forming, and then you pull again. So this pulling mechanical trauma, which is produced on the hair, may cause this exclamation mark type of hair. This is my explanation based on logic, not on studies, because I think such a mechanical study could be made, because we can reproduce this. You know, Trichorexis nodosa was reproduced in a lab. So probably if we take some hair, we take one hair from each of us and we will pull and we will see what happens. I think it's a study which can be done. So this is what I believe. And definitely exclamation mark hairs were seen in trichotillomania. They look a little bit different than alopecia areata, but you also mentioned a very important topic, because very often it happens that there's a coexistence between trichotillomania and alopecia areata. In many patients, especially in children, the disease is starting with alopecia areata, and then they somehow develop the habit of pulling the hair.
Lidia, I have another question. We have this entity of alopecia incognita.
Oh.
Sorry. Do you have some elements of science that can evoke, because it's difficult. We want to differentiate from a telogen effluvium, dystrophic anagen effluvium.
Yeah, I will say why I was laughing a little bit, because I have a problem with alopecia areata incognita. And alopecia areata incognita was first described by a huge hero of hair diseases by Dr. Rebora, and then also further explored by Antonella Tosti, whom I admire and love. But still, I do not agree full with the idea that alopecia areata incognita is a subtype of alopecia areata. It's my opinion. I would be happy to hear the opinion of from the pathology point of view. But looking at trichoscopy, I would have more the feeling that this is a combination of a very acute telogen effluvium in a patient with pre-existing mild androgenic alopecia. So this is my feeling. We have written this in the Blue Journal, in the JAD. I also understand the point of view of Antonella, who is saying that this is alopecia areata. But sorry for not being able to answer your question.
So do you suggest then to have a biopsy, because during the incognita you should have some signs of alopecia areata?
Yeah.
We'll ask the pathologist.
Yeah, we'll ask the pathologist. I don't know who of you is giving the pathology lecture. Axel. Yeah, what is your point of view?
I think in the microscope you cannot differentiate alopecia areata incognita or classic form. It's very difficult. And there is no correlation with the duration of the disease also, unless it's very long lasting. At the histology point of view, is the same.
So maybe you're right.
Yes.
So it's really difficult to say, but also it's I don't want to mess up with very specific things. But there is a recent pathology paper which shows that also the inflammatory infiltrates in an active phase of androgenic alopecia, they're quite big. They're localized a little bit differently because they're more superficial, and in alopecia areata they're more deep. But I think that we simplify the world of hair diseases, dividing them into a limited number of diseases, and probably the number is higher. And I don't know where to put alopecia areata incognita, but in my opinion, it doesn't fit into the diagnosis of alopecia areata, also for the reason that it regrows with either spontaneously or with topical treatment, which is quite unusual for other forms of alopecia areata. So it's you touched on a very difficult topic.
So it's a very good way to introduce the next speaker. So I have the pleasure to introduce my colleague and friend, Dr. Léopold Secco. Dr. Secco is a French dermatologist who works both in dermatology and pathology in Clinique Universitaire Saint-Luc since 2021, and he recently obtained an international board certification in dermatopathology. And he will talk to us about pathological aspects of alopecia areata.
So, hello to everyone. Thank you for the kind introduction, Alex. And I will talk to you about pathological aspect of alopecia areata, which is a very difficult topic for dermatopathologists because we don't see very much biopsies of this disease. So it's very difficult to study, and also even dermatopathologists are not used to see biopsies of hair, and it's a complex organ. So to start, the definition of alopecia areata histologically, it's difficult to define. We can say it's a non-cicatricial hair loss, which can be sometimes inflammatory, but it's not necessarily inflammatory. And we can describe several stages of this disease: acute, subacute, or chronic. But it's difficult to correlate with the clinic. There is a temporal-spatial variability. So just let's have a quick reminder about normal hair. You know that the hair can be divided between their size and their cycle. There are two types of hair in the body: the terminal hair, which can grow in the scalp or in the inguinal region, for example, in adults. And you have vellus hair, which are tiny hair, which you have in all your body except palm and soles. Each type of hair, vellus hair or terminal hair, have the same cycle. The longest part is the anagen part, which lasts several years. Then you have the catagen part, which lasts several weeks, and telogen part, when the hair is falling, which lasts approximately 3 months. So here on the right you see a normal picture of a biopsy with long hairs, which are deep-seated in the subcutis, and those are terminal hairs. The anatomy of the hair is also complex. There are several parts of the hair. From the top to the deep, you have the ostium, where you see clinically. The infundibulum is the part between the ostium and the isthmus, where the sebaceous duct of the sebaceous gland is going in the follicle. The suprabulbar zone is where are located the stem cells of the follicle, which can permit him to regenerate. And below you have the hair bulb. And here you have the hair with the follicle. At the right and the left you have the sebaceous glands. You have also the stem cells and the muscle of the hair. So this is the part which is mostly affected in alopecia areata. It's the bulb. You see two parts in the bulb. You see one part which is blue, basophilic cells, which are called matricial cells, which fabric the hair, with melanocytes to give the pigmentation. And you have the matrix, which is the mesenchymal component of the hair. So basically, in alopecia areata, you have two types of findings. you have first of all inflammation, which can be absent, and you have modification of the follicle, which are consistent. So first of all, the inflammation. What you can see in alopecia areata, which is an autoimmune disease, is an infiltrate of lymphocytes. And they are located around the vessel in the dermis and also around the bulb. And when they are numerous, they can form swarm bees. And sometimes you see some eosinophil in the infiltrate. So here you can find a sparse perivascular infiltrate of lymphocytes inside the interfollicular dermis, which are located around the vessel in the upper part or the deeper part in the dermis. They are also located around the bulbs, and they form swarm bees. So here you have still a normal bulb with mesenchymal cells and also lymphocytes around. Here you don't see very numerous lymphocytes. It's not very frequent to see very much lymphocyte around the bulb. And here also you see several bulbs, and around the bulbs you see the lymphocytes. And what is a clue for alopecia areata histopathologically is the presence of eosinophils. Alopecia areata is an autoimmune disease, and it's rare in autoimmune disease to see eosinophils in infiltrate. For example, in lupus, you don't see eosinophils. So when you see them, you can make confident to diagnose alopecia areata. So here there is a residual fibrous tract. The bulb has completely disappeared. You can see one or two epithelial cells which is entering in apoptosis, and you can find in the infiltrate one or two eosinophils. So the second alteration in alopecia areata are the modification of the follicle. What you can find is abnormal bulbs and follicles because the infiltrate is around the bulbs. You can find sometimes broken hair, which correspond to exclamation point hairs. And you also can find fibrous tracts when the bulb is destroyed. So just to compare, the bulb where the site where the lymphocytes goes destroy the epithelial cells. So at the left you see a normal bulb, and on the right you see a bulb which is completely broken. It's not normal. You see the difference. Here you see a residual eosinophilic cells which are entering in apoptosis, which are not anymore blue, and you have this fibrosis around with still the papilla present. Here on the right you have a destroyed hair, and on the left you have a normal terminal hair. You see the difference. There is a huge broken hair in alopecia areata. And what you can find also is the difference between the hair, which are entering in apoptosis, and the sebaceous gland, which are normal in size or hypertrophic. What you can see also is what you see clinically. So as showed in Lidia, is the keratotic plugs with sebum and keratin in the ostium of the follicles, which are dilated because there are no more hair shaft inside. Here you see a dilated ostium with hyperkeratosis. Here also you see very big keratotic plugs. And if you look closely, you can see sometimes broken hair inside with a residual hair shaft, which is very tiny, which form a clump of pigment. And this is a clue for alopecia areata. And when the bulb is totally destroyed, it's replaced by fibrous tract. So at first glance, when you see a biopsy of alopecia areata, when there is no inflammation, you can think about a cicatricial alopecia because you don't see any hair. But in fact, you have to imagine the hair which have disappeared. And on the left, you see a vertical fibrosis which contains some vessels and mesenchymal cells, which are still there, but there are no more epithelial cells. And what's a clue also for alopecia areata is that as the epithelium of the bulb is completely destroyed, you remember I told you that there are also melanocytes, and the melanocytes are also destroyed, and you can find clumps of melanin inside the fibrous tract, which is very evocative. So let's talk about the differential diagnosis of alopecia areata in histology. It may be confounding with syphilitic alopecia, but in syphilis, usually you see plasma cells around the bulb, which are not a feature in alopecia areata. You don't see plasma cells. And you can also be helped by the serology and the immunohistochemistry, who can show the bacteria. The other disease which is very close to alopecia areata is another autoimmune disease, which is lupus erythematosus. But if you look closely to the biopsy, you can find the classical signs of lupus as mucin in interstitial dermis. The lymphocytes also are not only around the bulb, but also around the adnexal structures as the glands, which are not a feature in alopecia areata. The sebaceous glands and the eccrine glands are spared. In lupus, you can also see plasma cells, but not in alopecia areata. And sometimes you have degeneration of the interfollicular epidermis. And if you perform it, a positive direct immunofluorescence. Also, what I told you is that eosinophils are rare in lupus, so if you see eosinophil in the infiltrate, you have to doubt about your diagnosis of lupus. And also, sometimes psoriatic alopecia can be confounding because the patient apply steroids on the hair and the interfollicular epidermis can be normal. But in psoriasis, there is a useful clue is the atrophy of the sebaceous glands, which are not a feature in alopecia areata. So look at the glands, and if they are atrophic, think about psoriasis. So to sum up, the histopathological aspects of alopecia areata, it's difficult to sum up because it's very complicated, but to be simple, you have a normal total number of the hair. Even if you don't see them, you have to imagine them by counting the fibrous tracts. You have inflammation around the bulbs, but the inflammation can be absent. You have increased miniatures and telogen hairs, and sometimes when the hair try to regrow, they don't regrow normally. So we see hair who are not vellus nor terminal, and we can call them nanogen hair or hybrid hairs. And you have consistent degenerative changes of the bulb. So I thank you for the intention and the invitation.
Thank you, Leopold, for this really nice presentation. It was interesting to have this correlation with clinic trichoscopy and pathology. I was wondering if, let's say that I have studied an immunomodulatory treatment and I'm not the best at trichoscopy, does it make sense to make a biopsy to look for sign of hair regrowth?
Yeah, I don't understand the question. If you start
yes,
medication,
I've started something and I don't see a lot of new hair on the trichoscopy. I would like to be sure that maybe the infiltrate has gone, or I see vellus hair in the follicle on pathology.
Yes, we can count the follicles which are vellus or terminal, And it can help the clinician, yes, to have an idea if, like morphia, for example, if there is infiltrate in the sclerosis, it can be challenging to give immunosuppressant and to give a treatment. Yes.
I have a question from the public. Is there a known explanation to the presence of eosinophil in alopecia areata?
I think it's about the Th2 microenvironment.
Okay. Short answer. Good answer. Est-ce qu'on biopsie souvent les pelades?
No, there is not so many biopsies of alopecia areata. For example, in Saint-Luc, we have 20,000 biopsy samples a year, and I think these two last year we had like less than 10 biopsies of alopecia areata. So it's not very frequent. We have alopecia under the microscope, so that's why it's difficult for us also to analyze. And maybe if the clinician would make more biopsy, we will be better to understand also the disease and the inflammation and how it evolves.
And I come back with a question quite similar to Axel, because we know we are on the phases, and we will have some explanation about new therapies. We have patients who are waiting for very long to have these therapies. Should we advise finally to do a biopsy to see if we have some hope? But we know that we are limited by the size of the biopsy, so maybe we are not on a good place. So is it good advice?
No, it's not my advice, but I think if clinically and if the diagnosis is evident and the patient has received previously several immunosuppressants, the next step is the anti-JAK therapy. So it's not necessary to perform a biopsy, but because the patient have the right to have this treatment, even if there is no inflammation. So,
but even if you see a fibrotic and the absence, total absence of you think that you can have a regrow?
Yes, because the stem cells are not located in the bulb, and they are located upper part, and this part is usually not affected in alopecia areata. That's why the hair can regrow. So in the microscope we don't see them, the stem cells, we don't see them easily. So we are not able to say if there are still some stem cells to the hair can regrow.
So finally we cannot give an answer. So
no.
Don't be a biopsy.
No.
Okay.
But if we take a biopsy, is there an advice how to take the biopsy for the pathologist to see as much as possible from which area, or any advice for the clinicians?
I think where there are exclamation point hairs and black dots, it's the most useful area, of course. Mm-hmm.
Yeah. I think it's time to leave the floor to Professor Ulricke Blume-Peytavi. Professor Ulricke Blume-Peytavi is Vice Director of the Department of Dermatology at the Charité. Charité is a part of the Free University of Berlin. She's well known in the field of hair, and today she will speak about physiopathology and the new insight in therapy. Thank you, Ulricke, for being here, even online.
Hello, good evening. Good evening, ladies and gentlemen, dear colleague. It's a great pleasure to be tonight with you to talk on alopecia areata, insights in pathogenesis and new treatments. These are my conflicts of interest. As you've heard from my colleagues, alopecia areata presents with a broad clinical spectrum, and your patients have a high emotional burden. To answer the demand of patients how to manage this hair loss and what to treat, you have to ask different questions. So, shall we treat or shall we not treat? We have to keep in mind that 40% of all our patients show spontaneous regrowth in the first 6 months. 70% show regrowth within 12 months. However, with persistence of alopecia areata after 12 months, without treatment, 30% progress to alopecia totalis and even 15% to alopecia universalis. So we evaluate the extent of the SALT score, so the extent of the hair loss, using a calculation of all areas devoid of hair on sides of hair, crown and occipital area, and what are important to consider for intensive treatment are severe alopecia areata with a SALT score 50% to 95%, and very severe, the most difficult to treat, is totalis and universalis. Available therapeutic approaches until recently you are quite aware of: wait and see strategy, topical or other application ways of corticosteroids, topical minoxidil and other immunosuppressive treatments were also used, or DCP therapy and signaling. However, there was a long-standing need for new therapeutic effective approaches. So what do we know on the pathogenesis of alopecia areata? It comes to an immune privileged collapse and leading cytotoxic T cells to invade the dermal papilla of the hair follicle, and clinically you see broken off hairs, exclamation mark hairs, and hair follicles devoid of any hair shaft. So what's happening within the hair follicle? In fact, we have an invasion of these cells within the hair follicle, recognizing autoantigens, most probably melanocytes or melanin, within the hair follicle, and these cytotoxic CD8 positive cells increase their synthesis of interferon gamma, leading to an immune cell activation. And then you see here in this scheme demonstrated, it comes to binding to the interferon gamma receptor, and via YAC signaling it comes via STAT proteins to enhance synthesis of interleukin 15 by follicular epithelial cells, further on continuing the loop to signaling downstream with stimulating even further these CD8 positive cells. So if you do not interrupt this loop, this cascade is continually continuing. So the approach is that in fact by blocking this YAC signaling, this was a new idea, you could possibly interrupt this pathogenic pathways. And we do know that any cytokine receptor signals through different combinations of 4 different JAKs and 7 STAT family members. And you know these different molecules also from other diseases like atopic dermatitis, rheumatoid arthritis, and what we do know also is that in fact our current knowledge is that Janus kinases mediate signaling of multiple cytokines in chronic inflammatory diseases, and you see it's not only Th1 and Th2 cells which have been recognized, even Th17 and Tregs. And in fact, alopecia areata plays a role in these signaling pathways, or is involved in its pathogenesis, shows here some aspects. And thus, this has led to a rapid development of candidates using for treatments in alopecia areata. This is a table from last year as candidates who were used in clinical studies. And when we come to this new treatments, which I would like to discuss with you today, is that we had last year in June already our first JAK inhibitor licensed for treatment of alopecia areata. And As you may have seen, perhaps, that is that baricitinib 2 and 4 milligram was compared versus placebo. Here you see the data achieving a SOLT score below 20 after 52 weeks in nearly 40% of all patients, and even nearly 30% a SOLT score below 10. You must know that all participants of these studies were always with a SOLT score above 50, and most of them were alopecia totalis or universalis, so severe and very severe patients. And when you ask, is there a difference in response, you can say yes. With severe alopecia areata, there's a much better response to treatment. With here you see 4 milligram, but also with 2 milligram compared to very severe, which have a lower response rate. And what is interesting also, that when you look on the pooled data of all done studies after 1 year, here you can see that you not only have the response on the scalp hair, but you see here also the eyebrows and the eyelashes responded as well very nicely over the time, with a continuous increase over 52 weeks. And when you look at the results after 104 weeks, you can say that the effect, the meaningful scalp hair regrowth, is maintained through week 104. So, and also eyebrow and eyelash growth continued to improve through this 2 years data. When you ask for risk and the risk assessment, you can see here there's the adverse events reflect the underlying risk of the alopecia areata patient population. So there is no higher risk observed in the population who took baricitinib for their treating the alopecia areata compared to the overall population. So
the second new treatment, which has been approved for alopecia areata in severe and very severe cases, is rudnicka, which was approved by the EMA in September this year. What should we know on rudnicka? Rudnicka has a dual mode of action which targets key immune system activating interactions. As I have informed you beforehand, interferon gamma and interleukin 15 are important drivers of alopecia areata. With this continuous loop in signaling between CD8 positive T cells and the hair follicle epithelial cells, this positive feedback loop signals via Janus kinases 1, 2, and 3, as you've already learned when I was talking on pathogenesis. However, what's interesting when looking on these cellular interactions and signaling is that there is an important factor, is a T cell receptor, which has also important interaction here. He's here located, and the immune attack by CD8 positive cell requires this autoantigen recognition by this receptor. So there are 3 families of the TAG family of kinases which are involved in signaling downstream from the TCR: TAG, ATK, and TXK. So in the scalp of alopecia areata patients, a specific T cell receptor signaling signature, including ITK, has been shown in activated T cells. So when we look on the efficacy data coming out from this 24-week study comparing different dosages of ritlecitinib, you can clearly see that the loading dose with, here in pink, with 200 milligram and then 50 milligram once daily, has after 24 weeks the highest efficacy. The loading dose 200 and then 30 milligram once daily is less effective. However, 50 milligram once daily, the dosages which is now licensed also, has also superior effect compared to 30 milligram. When we look on the SALT score, always what is our target is achieving a SALT score below 20. So below 20% of areas devoid of hair. So when we look here on this summarizing slide, is that you can see here the response to placebo after 24 weeks. And then when you look on 10 milligram ritlecitinib, slightly only superior. But when you then continue to look on 30 milligram and loading dose 200 with 30 milligram once daily, this is significantly superior. But what is really superior is the dosage of ritlecitinib, 200 milligram dosing, loading dose followed by 50 milligram. And this response to treatment is enhanced over 48 weeks and steadily increasing. What's interesting also is those who were on placebo, who were up-titrated to different dosages, 50 milligram or with a loading dose or without loading dose, they also reach comparable outcomes after 24 weeks. So in fact, even when treated retarded, they can still achieve good outcome. So of course you ask for side effects when you look on alopecia areata treatments using JAK inhibitors or ritlecitinib, JAK3 and TYK inhibitor. So of course you can observe in different groups, you observe different side effects also in the placebo group, but there are patients more frequently with treatment. However, when you look on the adverse events occurring in more than 10% of patients, it's mainly headache, nasopharyngitis, nausea, or acne, or severe adverse events are very low, also in placebo group, but only individual cases. So to the important question, what's about side effects using JAK inhibitors? In fact, when you look here on this systematic review, which has just recently been published, you have to keep in mind that there is, for the class of JAK inhibitors, oral and topical ones, an FDA boxed warning label for increased risk of major adverse cardiovascular events, venous thromboembolism, serious infections, and malignant neoplasm and death. But this box warning was precipitated as a result of the oral rheumatoid arthritis trial surveillance study, where only patients with rheumatoid arthritis were included. So the systematic review, which I am referring to, investigated 35 randomized clinical trials containing over 20,000 patients with dermatologic conditions. And in this systematic review and meta-analysis, no significant differences was found between JAK inhibitors and placebo or active comparator in composite MACE and all-cause mortality or venous thromboembolism. However, limitations of the systematic review were mean follow-up was only up to 5 months. So there is need for long-time follow-up in different immune-mediated inflammatory skin diseases however, as far as we can say today and what we have learned from studies using JAKs in alopecia areata, this risk is within the normal background rate of the disease. What else have we as new treatments? In fact, I just wanted to take an example of diruxolitinib as a representative drug which is still in clinical trials. And when you look here on the dose finding study using diruxolitinib in moderate to severe alopecia areata, you can see also very good response rates here in green, comparing 12 milligrams twice daily to 8 milligram in turquoise here in 8 milligram twice daily. So in fact, these two dosages are superior to other doses studied, and they are also the ones used now in the current phase 3 clinical trial. So to conclude, what we do have today is in alopecia areata, we do have targeted therapeutic approaches. What we do know is that today different signaling occurs, which is mainly regulated by Janus kinases, and cytokines which are possibly implied in the pathogenesis, such as from Th1, demonstrated in blue, and in violet here at Th2 population, there are different cytokines playing a role, such as IL-4, IL-15, and interferon gamma. And what we do know, that it's not only Th1 and Th2, what we do have as implied cell populations and cytokines, is that we also have others involved, but mainly based on our first understanding now of alopecia areata, we do have selective therapeutic treatments available. With baricitinib, this was the first JAK inhibitor which was licensed in June 2022, and with risankizumab, a dual kinase inhibitor of the JAK3 tag family in this year. All other candidates, and there's a broad spectrum of different other molecules which are under investigations, are not yet available, but I'm sure that we will see new approaches arising. And if we look in the current literature, you can see that in alopecia areata there are multiple other biologics and Janus kinase inhibitors which are currently used for other indications, such as dupilumab, which inhibits IL-4 and IL-13 signaling. And what is reported in case years or in individual cases is that when atopic dermatitis is treated with dupilumab, also alopecia areata regrows. However, there has been also seen the occurrence of alopecia areata. So currently, there is not yet our final decision whether this will really be one new therapeutic approach. Others, such as aprocitenib or upadacitinib, are also discussed to have a favorable response in alopecia areata. So these selective JAK inhibitors type 1 are also interesting candidates.
To the end, saying that in the future, I'm sure that we will have further small molecules for targeted therapies, and we are looking forward to investigating these new therapeutic approaches in our children, adolescents with alopecia areata, because those are the ones who suffer the most and will have their whole life before them. So we have, with the current spectrum of therapeutic options in alopecia areata, an opening of a new treatment landscape. It's a disease with a high emotional burden and high demand from patients. We do have new understanding of pathogenesis and signaling, and I showed you today the first targeted effective therapies for management of alopecia areata, and I'm looking forward to answer your question. Thank you for your attention.
Thank you, Ulrike. I think you are online, still online. You hear us?
Yes.
Good
Of
evening.
course, very nicely. Hello.
Hello.
Ulrike, do you have already, with your experience of all this therapy, some ideas about prognosis factors that may help to encourage the therapy or discourage the therapy?
I think this is a very important question because we have to counsel our patients. And we have learned so far that, in fact, there are two factors which are important for deciding who is a good responder. And in fact, this is the severity at a treatment start and also duration, how long the disease has already been existing. So we know the shorter the period, the better the response rate. And so we know that severe cases, like only 50% to 95%, respond better than the very severe, as I showed. In addition, we have different patterns also how they respond. So we have those with severe forms have most frequently the early responders. So in fact, what we do see is that we have three types of responders also. And we can see also there's 1/3 who responds as early responders. And then there's a gradual responder who responds between 24 weeks and 36 weeks. And then we have late responders, and these are mostly those who have alopecia universalis or totalis. But in fact, if they have a short duration, they are also more belonging to the early and the gradual responders.
So you encourage to maintain a therapy so it's quite long?
Yes, this is the, in fact, you look when it's not that if you only have 12 weeks response rate, you would stop after 12 weeks. That's too early, because we see that another third response then between 12 weeks to 36 weeks. So, and if you do still, I would continue up to 36 weeks at least. So I think you can see then, if you don't have any hair growth, you normally start then seeing eyebrows and eyelashes. And I can tell you that in most of the patients, we have a response between 12 to 24 weeks. What I have the experience so far. It's short that we have experience, but as far as I have experienced.
And eyebrows are very important. It's one thing
also.
that affects a lot the patient. So yes. I see that it's a question.
Yes, Dr. Blume, there is a question for you. Is there any data in patients with history of melanoma? Is there an increased risk? And should we avoid JAK inhibitors in patients with a history of melanoma?
What we have now in melanoma, I'm not aware of this. There have been epithelial cells cancer, but what we have to learn, the time is quite short, and what we have known, these data stem from rheumatoid arthritis also, when the reports on skin cancer. And you must be aware that the rheumatoid arthritis population is an older population where already there's increased risk of non-melanoma skin cancer. So the knowledge is on non-melanoma skin cancer. But however, in alopecia areata patients, which are mostly younger, we have not had this experience so far from what we are aware of.
Yes, I totally agree. I believe that beyond what is most important is the patient profile beyond the molecule. The population with alopecia areata, as you said, is completely different in terms of comorbidities compared to those with rheumatoid arthritis. So of course we're going to need longer term studies, but I think that the data we have now are encouraging us to prescribe it even on the longer term, as you suggested. Mm. And there is another question. Someone asked if you combine a JAK inhibitor with oral minoxidil.
Personally, I have no yet experience with oral minoxidil. In Germany, we don't prescribe it that much. Oral minoxidil, it's more in Spain, I think, or in Australia, they use a lot of oral minoxidil. However, if we combine it also with topical minoxidil, it can enhance the hair growth, but there are no studies on this yet, control trial. I think it's up to the individual decision of the dermatologist and the patient.
Can I ask one question to Ulrike? Nice seeing you again. Other than being a huge expert in hair diseases, you are also a pediatric dermatologist. And I would like to ask, what is your first-line systemic treatment in a child with alopecia areata?
Thank you for this question. Personally, in children, I do topical therapies. In alopecia areata in children, for the moment, I use topical corticosteroids for up to 12 weeks, tapering it off over this period, and systemic treatments in children below 12. I don't use systemic treatments, and above, sometimes you can, when it's in adolescence, you can use. We have no JAKs yet available, except now with ritlecitinib, that's above 12 years, but personally I don't have yet experience. And what else was before the periods of JAK inhibitors or our new development was oral corticosteroids, but I don't like so much in children which are still developing systemic steroids. And what we have else is, this is very promising data. I've presented that at the EADV. There's a botanical drug, quasilium, which has been shown in topical application, very good response rates in children. However, I'm looking very much forward to look on our experience we will collect either with ritlecitinib above 12 years of age, or on the other hand, there will be with the pediatric study trials, there will be also with the other JAKs, there will be with baricitinib and so on. There will be pediatric trials, and I think this is the population which is suffering the most, because they know when they are adolescent that they have a career of an alopecia patient before them, and I think mostly these are the ones where I could imagine that if we start early treating them with an effective treatment with regrowth, possibly, as in other diseases like atopic dermatitis, we can taper it off also. So perhaps this is also interesting. But we have I don't have experience in children so far. I don't know whether you have in children already experience or from the studies perhaps, but I don't have yet.
Yeah, not much. Also, we are happy that ritlecitinib is coming. Fortunately, there is an option in our country to get, very difficult, but there's an option to get reimbursement. But ritlecitinib is going to be available from the age of 12, probably in January, so it's not available yet. And in some patients, but rather the older children, we were using cyclosporin. I have no good experience methotrexate, which is preferred by some of our colleagues.
You mentioned a very important point is we have licensed drug for an autoimmune disease, but unfortunately in many European countries it is not reimbursed yet. And I know that different nations, they are fighting for getting for their severe and very severe cases in adults, of course, currently reimbursement, and we will have to see how this develops. But I think it's important to know that's really an autoimmune mediated disease, alopecia areata, where patients are suffering enormously. And I think we have now finally a target therapy, and it's a shame that we're not able to provide it to our patients.
Thank you, Ulrike. I hope you can stay with us until the end. We have now Dr. Axel de Greef. Dr. Axel de Greef is a young dermatologist, but already promising because he's already received prizes from the Belgian Society. He has been supported by the FNRS. And today we'll speak about the real-life experience with baricitinib in severe alopecia areata, 1 year follow-up data in a tertiary university hospital. Thank you, Axel, of being here.
Thank you, Dr. Del Marmol, for this kind introduction. So tonight I'm happy to present to you the real-life experience with baricitinib in severe alopecia areata. It's coming from a 1 year follow-up study that we did in Clinique Universitaire Saint-Luc. So as we've been talking, alopecia areata is an autoimmune disease characterized by non-scarring hair loss, and it affects approximately 2% of the general population. And although it is not life-threatening, it is associated with psychological comorbidities, and it has a major impact on the quality of life of the patients. And until recently, we only had conventional systemic treatments to treat them, such as corticosteroids or methotrexate, that only offered variable responses and frequent relapses at discontinuation of treatments. And since interferon gamma and interleukin-15 and JAK signaling pathway are key drivers in this pathology, it made sense to try to inhibit gynous kinesis, and it was done in BRAVE AA1 and BRAVE AA2 trials with baricitinib, JAK1 and 2 inhibitors, and it showed its efficacy and its safety in an AA population of adults. So we wanted to assess the effectiveness and the safety of baricitinib in a retrospective monocentric real-life patient cohort, adult patient from January 2021 to July 2023, and we included patients with a SALT score of 50 or above. They were all treated with baricitinib 4 milligrams daily, and the main outcome was the percentage of patients that achieved a SALT of 20 and below at the end of the follow-up, and we reported all adverse events throughout the study. We included 19 patients, 13 of them were females. It was a young cohort. The median age was 35 years. And the duration of the disease varied from 1 month to 63 years with a median of 13 years. We objectified first sign of hair regrowth within a median of 6 weeks, so pretty quickly. The follow-up duration, the median follow-up duration was 13 months. And regarding the primary outcome, so SALT score below 20, all of our patients with patchy AA reached that outcome. So this is illustrated here with the first patient we included in the study. It was a woman in her 40s with a 32 years history of AA, and you saw that the last picture is at the follow-up of 15 months. A SALT clearly almost complete hair regrowth. You cannot see the entire scalp, but she was not complete hair regrowth, but clearly below 20. Totalis AA 1 patient over 2 reached that endpoint, and universal AA 2 patient over the 6 included. We went further and looked for a complete hair regrowth, so a SALT score of 0. There we found that a bit of more than half of the patients with patchy AA reached the complete hair regrowth. 1 patient over 2 with totalis AA, and unfortunately no patient with universal AA. And the median time that was needed to reach that SALT score, and this is important to know because that is what the patient is going to ask, when is my hair going to be fully regrown and how much time is going to take. And in our study, it was a median time of 8.5 months. We had only 2 patients with no hair regrowth at all, and it was 2 patients with long-lasting universalis AA. Interestingly, we discontinued the treatment in 3 patients with complete response. 1 patient maintained the complete response a year after that, and 2 patients relapsed quite rapidly. We decreased the dosage to 2 milligrams per day in 1 patient with complete response. He relapsed 4 months later, but remained below a SALT score of 20. Regarding safety, we had no report of major adverse events. The most frequent one was an altered lipid status, and most commonly an increase in total cholesterol levels. We had some reports of mild headaches at the beginning of the treatment, and transitory transaminitis and increased creatine phosphokinase. So in this study, when we pooled all the patients that have reached that endpoint, we are better than what was presented in the trials. All patients with alopecia areata reached the endpoint, so this is a very good news. A poorer response was observed for patients with universalis phenotype, and there was a risk of relapse after treatment discontinuation. In this population, in this young population, we treated them with high dose of baricitinib, and it was well tolerated. The safety data were reassuring, and only lipid changes were quite commonly noted, requiring a close biological follow-up. A major problem that remains is the accessibility of baricitinib, especially in Belgium, and that is partially explained by the fact that its consequences on quality of life and on a psychological level are largely, they still are largely under-recognized. If you want to learn more, I invite you to read the paper we recently published in Dermatology and Therapy, and I would like to thank my colleagues that worked with me on this article. To conclude, baricitinib is an effective and safe treatment for alopecia areata, and particularly for the patchy phenotype. There was a poor regrowth prognosis for patients with totalis or universalis AA, and there is a risk of relapse after treatment discontinuation that needs to be considered and discussed with the patient. Thank you very much.
Thank you, Axel. It was a question but disappeared 2 minutes ago. And the question was addressed to you, Ulricke. Do you prescribe systemic corticosteroids in bolus for alopecia areata? And what's your first-line systemic therapy if you don't have JAK inhibitors?
Thank you for the question. Yes, if I speak now on adults or adolescents which are stable in their development already from 16 years old, where the parents are really pushing and there's a high emotional burden and they really would like to try. Yes, I do oral corticosteroids. Personally, I don't do pulse therapy. I do during 1 week, I start with 1 milligram per milligram daily, per kilogram body weight for 2 days. So, for example, 75 milligram 2 days, then 50 milligram 2 days, then 25, and then 10 milligram. Then a 3 weeks break with only topical corticosteroids, and then I repeat my 1 week moderate oral corticosteroids. So this is if I don't have a possibility to give drugs for pricing, for availability, for age. And this is, yes, that's what we have done so far in treating our alopecia areata patients, but it's a broad immunosuppressive, it's not a targeted therapy, but yes, it belongs to my armamentarium. And what we should know also, still we do use topical corticosteroids, still we do use DCP, we do use our treatments, what we do have in mild, moderate, and even some severe patients, if we don't have drugs, yes, we still continue to treat as we did before. However, we are not that successful as we are with targeted therapy, and we have also side effects with systemic steroids.
And do you use zinc?
Zinc in yes, I do use zinc, oral zinc. Yes, supportive therapy together with topical corticosteroids. Yes, it's immune modulating. Yes, but this is I doing more than 30 years dermatology. That's what I did the past 30 years. So today we are 2000 soon 24. And I would love to be innovative and to offer innovative treatments. But I don't say I do wait and watch strategy. This is also not what my patients would love to have.
Do you have more remarks or?
Well, actually, I have a question because you mentioned that one of your patients had alopecia areata for 63 years. But
Yes.
I imagine, or please correct me if I'm wrong, that it was a 63-year history of the disease with regrowth and relapses.
Yes.
But how long did you see, or what did your patients were obviously all successful in the treatment? How long was the longest time from the last regrowth until the start of the treatment?
You mean the last spontaneous regrowth?
Any regrowth, you know, because I feel that the important factor, but it's a feeling, is time from not specifically the first episode of the disease, but how long the patient was without hair. It comes back to the discussion we had with Leo about the disappearing hair follicles. So the 63 years was like an episode and then regrowth and then episode and regrowth. Is this correct?
In this patient, he had been suffering from AA since 63 years, but he mentioned episodes of his younger age with high and downs, so regrowth and relapses. But it was more than, I think, 40 years that he had no sign of hair regrowth. And actually, in this patient with 63 years history of AA, was one of the one with no hair regrowth at all under baricitinib. So as you said, I think that maybe there was no hair follicle to regrow, to be there to regrow. And to answer the first question, I think that I agree that positive predictive response factor, I believe, is anything you have started before, anything you've started to decrease the inflammatory, the infiltrates, the multiple cytokines that have been presented here. So yes, I believe that the less you wait between two treatments, the more chances you have to have hair regrowth.
Thank you.
So I have a question coming from Belgium. Good evening. Are there studies going on that still include new patients? And I can answer yes. Many studies will begin in January in, I think, all the university centers in Belgium.
It will be with upadacitinib, and it will include adolescents and adults, so it's going to be very interesting.
And several centers are included, so they can go to the closer place. So I take the opportunity to thank everybody, and I take the last sentence from the public. Thank you for the nice presentation. Myself also, as we approach the end of this interesting webinar, I would like to thank the speakers who participated, you to participate until the end. And we hope we have captured your attention and provided you with some new insight on alopecia areata. We would like to thank also the sponsors who have supported the organization of this webinar, and I hope you will enjoy the rest of your evening. Thank you for your attention.
Thank you.
Thank you.